Good afternoon, everyone. Hopefully, you're able to see and hear me. Um, we're going to be talking today a little bit about the main reasons that nerves can cause pain, and then a little bit about why regular doctors are really unable to diagnose nerve pain even when it's right in front of them. Um, so, Um, we'll get started off. I thought I would start here a little bit by just a quick, simple review of um, nerve anatomy and the definition of the two main components of the system of the human body. So, the nervous system is divided roughly into two main categories. You have the central nervous system, which is the brain and the spinal cord, and the nerve roots in the skull base or the bony spine. Once nerves leave the skull base and leave the bony spine, they become peripheral nerves. So peripheral nerves are all the other nerves in your face, head, neck, chest, abdomen, pelvis, arms, legs, etc. Um, Peripheral nerves typically innervate skin or muscles. They make muscles move. They also innervate joints. And so that's basically what they do. Um, Peripheral nerves are like long wires. And so, if you touch the tip of your big toe, you're stimulating nerves that started all the way up in the spinal cord. And so it's not like a sequence of blocks that just get put together. It's one long wire, so to speak, that goes all the way from your spinal cord down to the tip of your big toe. So those would be the longest nerves, peripheral nerves in your body. But every area that you touch on your body is a peripheral nerve that you're stimulating that has its origin up at the spinal cord or in the base of the skull and up into the brain directly. Um, so understanding the nerve anatomy a little bit and the differentiation between central and peripheral nervous systems, there's three basic reasons why peripheral nerves can cause pain. We can dispense with peripheral. We'll just use the word nerve from now on. But there's three basic reasons why nerves cause pain. The first one is a neuroma. The second is nerve compression, and the third is neuropathy. And if you want to sort of throw in a honorable mention, you could say tethering or when a nerve gets stuck, and we'll talk a little bit about that too. But let's go through those main categories of why nerves cause pain one at a time. So, what is a neuroma? Um, Again, the best way to think about nerves, or at least the analogy that I like to use because everybody understands this, is think of a copper wire that has a rubber insulation coating around it. Everybody's had experience with one of those copper wires that are insulated with a rubber coating. Um, when you talk about peripheral nerves, you're really talking about two different types of cells. The copper wire represents the axon or the actual nerve cell. The rubber insulation around the copper wire is made up of cells that are sort of strung together like pearls on a string, and those are called Schwann cells. And they provide certain functions to the nerve axon itself. But that's sort of the best way to think of it is, the copper wire is the actual nerve cell, the axon, and the rubber insulation are these little beads on a string Schwann cells. Now, um, when a nerve is cut, and it's easiest to think about this by just simplifying it down to a single nerve cell, so one axon that's insulated by Schwann cells or the rubber coating. When in reality, a nerve, depending on the size of the nerve may be tens of thousands or hundreds of thousands or even millions of these axons all bundled together, depending on how large diameter the nerve is. But We'll just simplify it down to a single nerve cell. And so when a nerve is cut, so let's say you're using a knife and you cut your finger badly and lacerate one of the digital nerves, or a worse injury and you get a bigger nerve that's deeper. What happens is one end of that copper wire or the axon is still attached to the spinal cord, and that's where the nucleus of the nerve is. And so that piece of the nerve that goes from the spinal cord to the site of the injury remains alive. So it doesn't go anywhere. The downstream end of the nerve that's attached to your fingertip, for example, the Schwann cells remain alive. So um, nothing really happens to the Schwann cells, but the axon, the nerve fiber, or the copper wire will undergo a degenerative process and basically disappears. So what you're left with on the end that's attached to the spinal cord is you have an intact functional copper wire that still has electricity in it and the rubber insulation around that wire. On the downstream end from the injury site where the nerve was cut, eventually all you end up with is just the rubber insulation. So the copper wire kind of melts away and disappears. The Schwann cells, or the rubber insulation on the downstream end, are still alive and still functioning, and peripheral nerves are programmed to regenerate and regrow if the situation is right. And part of that has to do with Schwann cells emitting chemical factors that both on the end that's still attached to the spinal cord and the downstream end, the Schwann cells on both ends secrete chemical factors that both promote and attract the axon, the copper wire, to find that hollow tube, the insulation that now has no copper wire left in it, to find that hollow down the hollow tube and reinnervate whatever that nerve used to go to. And so that's what peripheral nerves are sort of programmed to do. So if the laceration of the nerve is done by a very clean, sharp instrument, and the two ends of the nerves remain pretty close together, it may regenerate on its own. Usually, it doesn't end up in a perfect repair, but usually you'll get functional sensation and movement back if everything is just perfect. But unfortunately, in the real world, that process is often frustrated, either because a significant length of the nerve is damaged, or one end of the nerve ends up sort of far away from the other end of the nerve, and there's a lot of scar tissue that builds up between the two pieces of nerve that's been cut. And so what happens is that the Schwann cells are still emitting their chemical factors to try and get that nerve to grow. And so on the upstream end, the end that's attached to the spinal cord, that copper wire, or the live piece of the axon that's still intact, will start to sprout and to grow down, trying to find that other end of the nerve. Um, Oftentimes what happens is it gets blocked by scar tissue. So you end up with this very sensitive nerve end that's now stuck in scar tissue and unable to complete the circuit, so to speak, and find that downstream end of the nerve and regenerate like it's supposed to. If the nerve is able to find the downstream end and regenerate, typically it doesn't end up being painful. But if the nerve fiber ends up stuck in a ball of scar tissue, then anytime that scar tissue is stimulated, whether it's rubbed by clothing or bumped or whatever, it ends up producing a painful sensation for the patient. Now, if you scale that up to a significant sized nerve, where you're talking about thousands or tens of thousands of axons, it can be an incredibly painful structure, these neuromas. I always think about them like if you think about a green onion, how the end of the onion there's a little bulbous structure before you get to the little nerve roots that are kind of poking out the end of the green onion. That's always what I think about when I think about a neuroma. It's a normal nerve that terminates in sort of an enlarged bulbous structure, And even though those nerve ends are sort of microscopic and you can't really see them with the naked eye, they're all sort of stuck in that ball of scar tissue. If that scar tissue kind of, or if the neuroma kind of heals up into scar tissue that's stuck to the skin, even just moving or stretching where that neuroma is stimulated can become a constant pain generator for the patient. So that's a neuroma. Basically, it's where a nerve has tried to regenerate but has been frustrated in that process, and you get all these sensitive nerve endings in a ball of scar tissue on the end of the nerve that's still attached to the spinal cord. So the nerve still has electricity in it and still functioning, but now instead of doing what it's supposed to do, it's just constantly producing a pain signal that is being relayed to the patient's brain, and so the patient experiences constant pain. The next reason that peripheral nerves cause pain is compression. And what this refers to is mechanical pressure that is exerted onto the nerve from surrounding structures or forces. This is probably overall the most common reason why nerves cause pain. The most well-known example of a peripheral nerve compression is carpal tunnel syndrome. Many of you watching probably have heard that term. Maybe you've had it, maybe you had surgery for it. But carpal tunnel syndrome is simply where the median nerve, which is the nerve that innervates, so if I hold up my hand here, the median nerve innervates the palm side of the hand, including the thumb, the index finger, the middle finger, and then this side of the ring finger and this part of the palm on that side. Over here, the other side of the ring finger and the small finger and this side of the palm is a different nerve. So carpal tunnel syndrome is where the median nerve that goes to the thumb, index finger, middle finger, and that thumb side of the ring finger and that side of the palm becomes compressed right here at the wrist level. Right in through here, this area here is the carpal canal. There's a very tough ligament that runs across this way, and then the rest of the tunnel is made up by the carpal bones of the wrist. So it's a defined space, and through that space passes all the flexor tendons to the fingers that allow you to make a fist and the median nerve. And it's a pretty tight space, but under normal conditions, everything fits fine there. If for some reason things change, whether that's because there's been trauma, like a broken wrist, so that the tissue around the nerve swells and closes down the amount of space for the nerve to live in, or if you have some other kind of an issue where the nerve itself might swell, either way, or another very common reason is if you're doing some kind of task where you are working all day, for example, where you're flexing the wrist, where you're bending the wrist like this, or keeping the wrist flexed in this position, which that increases the amount of pressure on that median nerve. So like this is less pressure, and if you do this, it's more pressure on the median nerve. So if any of those things happen over time, you can develop a compression of the median nerve. That's called carpal tunnel syndrome. So that's probably the most common example of a nerve compression. Now, there's many places in the body that a similar situation can arise where a nerve which has to pass through. Nerves are like wires again, and think about the wiring in your home. That's exactly sort of how nerves are in the body. They're the wiring of your body. And so as nerves pass down the arm or down the leg or travel to certain areas, at specific points for specific nerves, they're forced to pass through tight spaces. A lot of times these tight spaces occur around joints, but not exclusively. And these tight spaces are usually made up of an area where there may be partly bone and partly ligament or tendon, creating sort of a tight tunnel that the nerve and sometimes blood vessels have to pass through. If you think about the construction of your home, if you were to take off the drywall, you'd see the 2x4 wooden studs, and in between you have the insulation, and the wires are strung through the walls to go to your outlets and to the light socket and whatever. If you look at those wires, in between the 2x4 studs, there's lots of space. There's nothing that can put pressure on the wires. Where the wires pass through the tubophores, there's usually been a hole drilled, and so all the wiring has to sort of come closer together and force its way through that hole through the tubophore. And that's sort of how nerves in the body are. There's many places where the nerves, and sometimes they're traveling with blood vessels, sometimes not, but they're forced through tight spaces in the arms, legs, torso, etc. And so these are locations where the nerve has the potential to become compressed. Um, Now the last reason that nerves can cause pain is peripheral, or we'll just call it neuropathy. And there is some crossover between neuropathy and nerve compression. Um, a good way to think about it is that neuropathy is sort of best understood as a problem that may affect all the nerves or many of the nerves in the body at the same time, whereas a neuroma or a nerve compression usually just affects one or maybe a few nerves at a time, but generally not most of the nerves. What this means is that there's usually something on a systemic level that's affecting the nerves themselves. This can be some kind of a metabolic process like diabetes. There's a number of other risk factors. And usually what's happening is the underlying problem is causing changes to the nerves that then make the nerves susceptible to developing compression. Um, and and how this presents clinically is that typically because multiple nerves are involved, the patient will start to experience numbness that involves the whole hand or the whole foot. Peripheral neuropathy most commonly involves the extremities. Um, More often than not, it's the lower extremities, so feet and lower legs, but it can involve the hands and forearms, and many people have it in both their lower extremities and their upper extremities. So it just can vary from person to person. Nobody really knows why, one diabetic may develop neuropathy only in the feet and lower legs, and another one may develop it in the hands and feet. We're not really sure about that. But peripheral neuropathy is sort of a situation. I like to think about it as like a two-layer cake. So um, looks like the video may have just gone out. Can you guys still hear the audio? Okay. For some reason, sorry about that. For some reason, it's giving me a black screen. But as long as you guys are able to see everything, then it actually does me a favor. I don't have to look at myself the whole time. Um, so, okay, we'll get back to um, neuropathy and what's going on with there. I think I was just talking about how this is. I like to think of it as a two-layer cake. As we talked about a minute ago or so, there's always some kind of underlying process. So one of the most common groups of people with peripheral neuropathy are people who and then secondarily develop neuropathy. Um, if you have diabetes and you have neuropathy, they'll say you have diabetic neuropathy. If you have really any other if you don't have diabetes, maybe that's a better way to put it. If you don't have diabetes, they'll say you have idiopathic neuropathy. So there are a number of risk factors for developing neuropathy. One is certainly diabetes, but things like hypothyroidism, um, certain disease processes that involve in the autoimmune system or inflammatory processes like lupus or rheumatoid arthritis, um, heavy metal poisoning, arsenic, mercury, lead, those kind of things. Certain treatment with certain types of um, chemotherapy drugs, cisplatin, vincristine, those kind of things. There's just a number of risk factors that are known and associated with developing peripheral neuropathy, but there's a huge group of patients out there who develop peripheral neuropathy who don't have any known risk factor. They're not diabetic and they don't have any other risk factors that I mentioned, and yet they still clinically they present with the exact same symptoms as somebody who has diabetes or one of these other risk factors. So um, what happens for many patients, and I just want to be clear here. So just because you have peripheral neuropathy does not mean that you are automatically a candidate for surgery to alleviate the symptoms. For people that have peripheral neuropathy, they need to undergo a peripheral nerve evaluation. And if they demonstrate evidence of nerve compression, then nerve decompression surgery is typically about 80% successful in reversing these symptoms. So, back to the two-layer cake analogy for a second. The first layer is whatever the systemic or metabolic problem is that is affecting the nerves themselves. And the second layer of the cake is usually that first layer, the nerves tend to swell. There's other things going on, but just from a lay standpoint, the easiest way to think about it is these nerves generally tend to get enlarged and infiltrated and encompassed with fatty tissue. And so the same nerve in somebody who's normal and somebody who has diabetic neuropathy, the diabetic nerve can be twice the size of the normal nerve. Now, if you think back to where we talked about how nerves are like the wiring in your body and they're forced through tight spaces, if you have some kind of metabolic process that's causing your nerves to slowly swell over time, eventually the nerve no longer fits in that tight space. But you know, the process that's affecting the nerve doesn't care about that, and so the nerve just continues to swell, and eventually the tissue around the nerve, whether it be bone or a tendon or ligament that make up these tight tunnels, start to exert significant mechanical compression on the nerve itself. And it's actually that mechanical pressure on the nerve that typically produces the symptoms that most people, including all doctors, associate as being your peripheral neuropathy. So the symptoms like numbness, tingling, burning, aching, weakness, all those things that people with peripheral neuropathy experience, most of the time um, are due to the pressure that is developing on the nerve itself. And so, just like somebody, if you want to simplify it down, just like somebody who has carpal tunnel syndrome, the treatment for that is to surgically decompress the nerve once it gets significant enough. For people who have peripheral neuropathy and show good evidence on nerve examination that the nerves are compressed, and there's certain signs and things that we look for, surgical decompression of those nerves is very effective at relieving and reversing those symptoms. The difference with somebody who has peripheral neuropathy is that usually multiple nerves are involved at the same time. And that's why traditionally it's been sort of confusing for doctors, and why peripheral neuropathy, even in medical school today, they teach you that peripheral neuropathy is a progressive and ultimately untreatable or uncurable condition. The best you can hope for is to sort of manage the decline with things like narcotic pain medication and or neurogenic type pain medications like gabapentin and Lyrica and these other types of medicines like that. Um, Almost all patients with peripheral neuropathy do very poorly with these kind of medications. It may take the edge off, but it never, I mean, I wouldn't say never, but it rarely gives patients really great relief. And so, in addition to the fact that it's not really relieving the pain, very often these drugs have a lot of side effects that patients don't tolerate well. With narcotics, it's constipation and nausea and feeling looped out and drugged all the time. With some of these other neurogenic type of pain medications, it can involve weight gain, also feeling very groggy because all those medications act on the central nervous system, particularly the brain, and so it can depress your brain activity and make you feel like you're stoned or tired all the time or that type of thing. And in fact, some people, these side effects are so bad that they would rather deal with the neuropathy pain than deal with the side effects of the drugs. Um, so that sort of goes over the main three reasons why peripheral nerves cause pain. Again, just to review, where the nerve is cut, or sometimes if it's crushed badly enough, and that's where the sensitive nerve ends get stuck in a ball of scar tissue that's very sensitive, and any kind of stimulation causes pain. There's nerve compression, which is sort of dealing with a single or maybe a couple of nerves that have become compressed for some reason. So that's mechanical pressure being applied externally to the nerve and squeezing or squishing the nerve. And then you have neuropathy, where typically some type of systemic or metabolic disease process is causing the nerves generally to swell. And that's where you end up with peripheral neuropathy, where the the entire foot or the entire hand can feel numb and tingle and burn. And then I mentioned also sort of tethering of the nerve. And what can happen here is, nerves are made to glide across joints and through tissue as we move and walk and run and all those types of things. So if you have an injury somewhere or a surgical procedure somewhere, and the nerve that is supposed to be gliding through that tissue, um, it's not necessarily been damaged by the surgical procedure or the other trauma, but the scar tissue field is wide enough that it entraps that nerve, so that nerve is now stuck to a specific point and not able to glide anymore. What happens in that situation is the think of a rubber band. Instead of the rubber band being mobile at both points and just being able to slide back and forth, it's now fixed at one point. And so with movement, that rubber band is being stretched instead of just being able to glide back and forth. And that kind of a stretching force on a nerve also can be very painful. So those are the main reasons why nerves generate pain signals. And when one of these situations is present, essentially the nerve then is just generating a constant pain signal that goes to the brain and is interpreted by the patient as pain, but it can also manifest as feeling like pressure or something's being torn apart. I mean, literally, if you think of just about any sensation that you're capable of experiencing, that sensation can be reproduced by a nerve that's unhappy because it's been damaged or it's stuck or being compressed in some form or fashion. Um, so that sort of brings us to the second part of the discussion for today, which is, why is it impossible for regular doctors to diagnose nerve pain? And there's several points here that I just want to go over so that everyone watching this can get an appreciation. I'm always asked by patients, like, they sort of look at me with this horrified look on their face, and they're like, why is this knowledge not more widely available, or why don't all doctors know about this, or why didn't my doctor refer me to you 5 years ago or whatever? And the simple truth is that there's a number of reasons for that, and I'll go through them right now. First and foremost is the fact that no one learns or is taught peripheral nerve anatomy. It'd be like having an orthopedic surgeon who doesn't know anything about bones. When you think about it like that, it's kind of, it seems ridiculous. But in order to understand pain and to be able to diagnose pain, you have to understand peripheral nerve anatomy. The problem is that as a physician, you go to medical school. Um, back when I went to medical school, probably 20 plus years ago now, you have your first year of medical school, you have gross anatomy. So you dissect a cadaver and learn everything about, well, you don't learn everything, but I mean, you learn a lot about human anatomy during, that semester of medical school. The problem with peripheral nerves is a lot of important peripheral nerves run in the fatty tissue under the skin and innervate different areas of the skin. And the first thing you do as a medical student, first of all, you have no idea about dissecting or anything, so you're just kind of in there chopping and hacking away. But the first thing you have to do is sort of remove the skin and fat from the cadaver so you can get down to the important structures, the muscles, the bones, the internal organs, things that are easier to see and easy to be tested on, so to speak. And so, as you're going along, once your cadaver has had the skin and the fatty tissue removed, the superficial tissues, you'd be going along studying the muscles, and all of a sudden you'll see the cut end of a nerve poking up between two muscle bellies, and you'll be like, I wonder what that is, and where did that go? And then you don't give it a second thought, and you move on. So, essentially, you're taught nothing about peripheral nerve anatomy as a medical student. And as you go, if you don't go into some kind of surgical field, then that's really the end of any kind of exposure to peripheral nerve anatomy that you're going to get for all intents and purposes. If you go into different surgical fields, you may learn bits and pieces about peripheral nerve anatomy as they relate to different operations that you perform. And usually that takes the form of, there's a nerve here, we're replacing the knee joint. Don't injure that nerve, or don't, stretch it, because we don't want to have the patient have damage, not be able to lift their foot up, for example, after we put the new knee in. A crude sort of basic understanding of nerve anatomy, and usually geared towards not injuring or not having a problem after what you're doing is done. So that's the first step, and really the biggest problem is that nobody understands peripheral nerve anatomy. The second thing is that nobody ever learns the stories that go along with peripheral nerve problems. And what does that mean? Well, the reason doctors are good at diagnosing things is because they get familiar with patterns or stories in terms of how different disease processes or problems present. So one of the things that every medical student learns is the story that goes along with acute appendicitis. And so even 20, 30, 40 years after medical school, somebody who's never seen an inflamed appendix or ever operated and removed an appendix could probably still recognize the story that goes along with acute appendicitis, because you learn that in medical school. It's drummed into your head. And the story sort of goes like this. The patient, starts to feel sort of diffuse aching or pain around the umbilical belly button area. And then that may be sort of associated with some nausea, maybe diarrhea. Over the next 12 to 24 hours, the pain sort of seems to move down to the lower right quadrant of the abdomen where the appendix lives. And, they can get sicker and sicker, and the abdominal pain becomes more severe as time goes on. And eventually, you may not even be able to really push or tap on the belly because it hurts so much. Their white count will go up. They start having fevers, et cetera, et cetera. That story, if a patient comes in and you hear that story, virtually every doctor in the world is going to be able to make that diagnosis correctly and say, it's appendicitis, or at least something. Even if that's not the correct diagnosis, they know it's something going on in the abdomen, and they need a CT scan and see what's going on. And there's similar stories that go along with peripheral nerve problems, but the stories are very integrated with the anatomy. When you know the anatomy, it really turns the body into a puzzle. Like if you think about a puzzle with pieces of the puzzle, It's like overlaying a puzzle on the human body. So specific nerves go to specific parts of the body, specific skin, specific joints. Nerves are divided into sensory nerves, basically, which provide sensation, and those usually go to skin or or joints or other soft tissue in the body. And the other big division of peripheral nerves are motor nerves, and those nerves go to muscles. And when they fire, it makes the muscle contract, and so it produces movement. So if the patient gives you a good description of where their pain starts and how it travels, very often, even without seeing the patient, you can make the diagnosis of what nerves involved or what couple of nerves or whatever is likely to be. Um, you combine that with a good motor exam, so you're testing strength in all the muscles, and you start to see weakness in one or more muscle groups. That also keys you right in on which nerves are likely to be causing a problem. And because physicians are never taught the nerve anatomy, they're never taught the stories that go with peripheral nerve problems, and they're never taught how to examine the peripheral nervous system. Um, they're essentially operating blind when it comes to patients who have peripheral nerve pain. So, as I learned more about peripheral nerves during my fellowship and whatever, eventually the image came to me of Charlie Brown's mom. If you're watching a Peanuts cartoon, all the adults speak in that sort of wah 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 wah. And to me, I feel like when patients go in and speak to their primary care physician or the neurologist that's seeing them or their spine surgeon or whatever, and they're trying to talk to them about a peripheral nerve problem, I think to these physicians, that's what their patients sound like. They're essentially speaking a foreign language because they don't have any of the background information that allows them to understand or perceive what the patient is really talking about. There's a great expression that I came across years back, which is the eye can't see what the mind doesn't know, and that is so true in medicine, but particularly in patients who have peripheral nerve problems. When it's something that the physician, when that knowledge is not even in their database, they're never going to be able to see the problem, even if it's staring them right in the face. Um, so that brings us to some of the modern testing and stuff that can be very effective for other problems, but fail spectacularly when applied to peripheral nerve problems. The first is an EMG nerve conduction study. Almost any patient or almost every patient who complains of pain and numbness and tingling ends up getting one or more of these studies. And the problem is that they're notoriously unreliable. They do the best for carpal tunnel syndrome. There's still probably a 30% false negative rate. For cubital tunnel syndrome, which is entrapment of the ulnar nerve of the elbow, it's up to 50% of the time where those tests miss the problem when it actually exists. And then if you start combining things, so the more complex and the deeper the nerves are that are involved in the peripheral nerve problem, quickly EMG nerve conduction studies just completely fail to give you any kind of useful information. Doesn't stop doctors from ordering it and patients from having to suffer through them, but they're almost never useful in giving you information that you don't already know from your exam and from the history. And so for that reason, I can't even remember the last time I ordered one. They can be effective in the arena of reconstructive peripheral nerve surgery, which is where a nerve has been cut, and it is a nerve that has motor function, so it results in the loss of being able to use certain muscle or muscle groups. An EMG is most useful to evaluate that kind of a peripheral nerve problem, which is really a totally separate area from pain peripheral nerve problems. So functional peripheral nerve problems and pain peripheral nerve problems are really very different fields. But if you're dealing with a functional peripheral nerve problem, EMGs can help to give you insight about whether the nerve has really been lacerated, or maybe it's just been stretched and not functioning, but if you give it time, it'll come back and you don't need to operate. So it's useful in that area. If you have operated and you've reconstructed a nerve, EMGs can be useful in follow-up to see how the nerve is recovering and whatnot. But in terms of trying to diagnose pain-related peripheral nerve problems rather than you know, reconstructive peripheral nerve problems, EMGs are uniformly useless, basically. And so, you know, everybody with neuropathy gets an EMG, and all it does is tell them they have neuropathy. It never, almost never, shouldn't say never, but it almost never identifies the points of nerve compression that have developed secondarily. And if it does, it may identify one out of 4 or 5 different problems. So it's not really that useful. They're very painful for patients who have them, and they don't add a lot to the conversation, so I don't ever get them. The next thing that makes it really difficult for doctors to identify peripheral nerve problems is that all the imaging technology that we have that has made diagnosis of many other problems very accurate and really been a boon to the diagnosis process and many other things doesn't work for peripheral nerves. So, bones show up great on X-rays and CT scans and MRIs, ligament injuries, problems with internal organs, tumors in the brain, compression at the spine level involving the spinal cord and nerve roots are reliably imaged with MRI or CT scans. X-rays really only great for bones. Nerves don't show up at all on X-rays, but even on CT scans and MRIs, it's very, very hard to image the nerve reliably, and this is truer and truer as you get into smaller and smaller nerves. So if you're going to be able to image nerves with MRI, which is really the best modality for imaging nerve tissue, is a magnetic resonance imaging. It's going to be better at identifying large nerves rather than small nerves. Now, as many of you know, there's sort of a newer type of an MRI called an MR neurography or MRN, and this is the very best imaging technology we have for visualizing nerves. But even that fails to identify smaller nerves very often. And even in the other problem about an MRI or an MRN is even if it's able to visualize the nerve, many times it doesn't give you any good information about is there a problem with the nerve. So yes, I can see the nerve, but is the nerve compressed? A lot of times that information can't be gathered by even MR neurography. Sometimes if there's a lot of inflammation of the nerve due to the compression, it'll show up, but many times it doesn't. And so there's no consistently reliable way to image or visualize either electronically with an EMG or with imaging peripheral nerves on any consistent manner. And even if you can visualize them, often it's impossible to tell that there's a problem at this level versus that level and what the problem is. The exception is sometimes with a larger nerve, if there's a neuroma, certainly you can sometimes visualize that. Ultrasound occasionally can be useful in visualizing some of the smaller nerves if there's a neuroma or something like that. But again, it's very hit and miss. So there's no reliable technology we have that a doctor can order this test and just it comes back and says the problem with the patient. The pain is because the tibial nerve is compressed at the soleus sling level and the tarsal tunnel level, and that's why they have pain and numbness in the bottom of the foot. Doctors can't do that. You have to understand which nerves innervate what and be able to perform a physical exam to get that information, and doctors just aren't taught that kind of stuff. And those two things together are really the big reason why it's impossible to diagnose nerve pain for doctors. And then there's another component to this, which is that the paradigm of how we treat chronic pain in modern medicine is completely wedded to the idea that most pain, even acute pain, the treatment for it is something that you can put in your mouth and swallow. Now, we do a pretty good job of treating acute pain. For acute pain, narcotic medication works pretty well. Other types of pain medication work well. Very often, it's easy to identify the source of acute pain. You've broken your femur, or you've had a surgical incision, and so we know where that pain's coming from. We give people pain medication, and it usually controls that kind of pain very well. The exception is if a nerve's been damaged or if a nerve is acutely compressed. Um, but then that often will confuse the doctors because they sort of are thinking in terms of acute pain from other reasons. And so as pain lasts longer and longer, eventually it becomes quote unquote chronic pain. And that just depends on how you want to define the length of time that you have pain before you term it chronic pain. A pretty common one, though, is 6 months. If your pain persists longer than 6 months, you can safely say that this patient is experiencing chronic pain. And and the big problem with chronic pain and the way we think about it in Western medicine is that, once the patient is deemed to have chronic pain, so their broken bone is healed, the surgical incision is healed, or the laceration or the bruise is gone, all the visual manifestations that might make us think that this patient has a reason to have pain, all that's gone. And what remains is the nerve injury. It could be a neuroma, it could be a nerve compression, the nerve could be stuck, etc. And again, all that's more or less invisible to doctors who don't understand the anatomy and don't understand the stories that go with those types of nerve injuries. And so, ironically, doctors just sort of take their thinking caps off once the patient develops chronic. It moves from a situation where we're trying to find the cause and treat the cause to, oh, okay, now you have chronic pain. Now we're just going to try and manage the pain. And so they're sort of resigned to the graveyard of pain management, as I like to call it, because in most situations, pain management doctors are not able to diagnose the source of the pain for the same reasons that every other doctor isn't. They don't know the peripheral nerve anatomy. They don't understand the stories that go with these things. There are certain types of pain problems that pain management can address pretty well and fix. Usually that involves problems that are spine related. So if there's something that's inflamed or swollen and putting pressure on a nerve root or a spinal cord, sometimes these different injections that they do, epidurals, nerve root blocks, etc., can be very effective. If it's spine pain because of arthritic joints in the spine, that can be effectively managed by radiofrequency ablation of the little nerves to the facet joints and other things like that. But for the most part, when the patient is dealing with a peripheral nerve problem and has been sort of shuffled off to the arena of pain management, that's like a death sentence for that patient. They'll never get better. And unfortunately, as I've stated before, the techniques and approaches we have for dealing with peripheral nerve pain are uniformly ineffective. So, the tools in the pain management tool chest for dealing with chronic pain, especially nerve pain, basically consists of narcotic medication, neurogenic pain medication like Lyrica and gabapentin, pain pumps, or some kind of nerve stimulation, usually a spinal cord stimulator or a dorsal root ganglion stimulator. They have newer peripheral nerve stimulators which don't work well, and most of the time they have trouble even sort of identifying what the nerve is, so those kind of put them in where the pain is, and it just doesn't work well long term for the patient. But that's sort of all that they have in their armamentarium to treat nerve related pain. And so unfortunately these nerve pain patients just languish in pain management clinic in horrible pain, while at the same time can be on enough narcotic medication ramped up over time to kill a horse. And also, doctors get very sort of fixed in the way they think about things, and so chronic pain, we've been treating it for 5,000 years by popping a pill. Essentially, the Egyptians used to cultivate opium and would smoke it for pain relief or whatever, make salves and other things. But so we haven't really progressed all that much in terms of understanding and treating chronic pain up until the development of this field of surgery, which is pain-focused peripheral nerve surgery. Um, the other saying that I came across, which sort of really describes a lot of doctors, is that the greatest barrier to learning is not ignorance, but the illusion of knowledge. And and this is really true in medicine. A lot of doctors go to, they're pretty smart people to begin with. They go to medical school, they go through years and years of training. And when they get finished with all that, and then many of them have years and years of experience practicing their specialty. And when they get, when they've done all that training and had all that experience, it's very hard for them to accept that there's a whole area of anatomy, physiology, and dealing with pain that they really know nothing about. And so it often can be that ego that prevents them from having that aha moment and being able to see how applicable this technology is for many, many patients who suffer with chronic pain. Um, I think that's basically more or less everything that I have to say about why nerves cause pain and why it's more or less impossible for doctors to diagnose nerve pain. Again, just to reiterate the anatomy component, which is the single biggest problem. Um, I'm sure many of you know what the Rosetta Stone is. That was a black stone that had several different languages on it. I think it had Greek and Egyptian and one other language on it, and it was the means by which they were able to crack the code and understand Egyptian hieroglyphics and read all the writing on the pyramids and everything. And the way I think about this is understanding peripheral nerve anatomy is really the Rosetta Stone to cracking the code to understanding chronic pain. And without the nerve anatomy understanding, there's just no way that you'll ever understand chronic pain in a meaningful sense. Um, so, having said that, I think I'll just go through some of the questions here. There seem to be a lot of them, and we'll just answer all of them. And when we're done, we'll go do something else. Um, so, the first one here the comment is, I have not been able to leave my bed for 3 days due to pain. Her doctor gave me diazepam, but it's not taking the pain away. So, first of all, diazepam is not a good pain medication. If you're experiencing some kind of discomfort secondary to anxiety, then diazepam might work well, but it's not a pain medication. And this is sort of a classic thing that doctors do is they just wallpaper over the patient's complaints with a medication like diazepam or Percocet or whatever. They don't really understand what the patient's telling them. They don't understand where to start even. And so it's very frustrating and confusing for physicians, and they don't like to feel like that because most of the time they're able to deal with various issues and have a good outcome for the patient. So again, I don't know exactly why this patient is in pain, but the more doctors a patient sees and the more time elapses without an obvious diagnosis or an effective treatment, the more likely the patient is that they have a peripheral nerve problem. I see a patient of mine from Quebec, Canada says hello, so hello. The patient here says hello from San Diego. I've had CRPS for 25 years. I had a pump for years, but now I'm on a high dose of Nucynta because my pain is so horrible. I love my doctor, but he's retired. I know there are so many good treatments. I'd love your opinion on what to try to get off my super high dose and help get rid of the brain fog. Thank you. So, again, here's a patient who has been diagnosed with CRPS. I'd encourage this person to look at the Facebook Live that I did on CRPS, and there's other information on my website and stuff. But CRPS, which stands for complex regional pain syndrome, is really sort of a throwaway diagnosis for what is really usually a solvable peripheral nerve problem. Again, because doctors uniformly don't really understand peripheral nerve problems, they've come up with this term CRPS to describe the constellation of symptoms that they see. So it really depends, and sadly, sometimes CRPS problems are complex, and the longer they go on, if it's a complex problem, the more difficult they are to treat. So time is of the essence. But sometimes a problem like CRPS can be a very simple thing to fix. It might just involve one nerve, for example. And I should also say, very commonly, patients are actually misdiagnosed as having CRPS. They don't even there's a whole set of criteria for actually making the diagnosis of CRPS, but most of the time doctors are just lazy and numbness and tingling and burning, and they can't figure it out. They're like, oh, you probably have CRPS. And once that gets put on the chart, then it just gets propagated. Everybody sort of shuts their brain off. They're like, oh, you have CRPS. Okay, well, this is what you can do, or you just have to live with it, or whatever. So for this patient, what they really need to do is see a peripheral nerve expert. And again, that doesn't mean go to UCLA and ask for who does peripheral nerves, because that doctor won't have any idea about how to help you, because again, there's a huge difference between a reconstructive peripheral nerve surgeon and a pain-focused peripheral nerve surgeon, and there are very, very few pain-focused peripheral nerve surgeons. But that's what you need to do, is see a pain-focused peripheral nerve surgeon, and have them evaluate you and see if it's something that can be fixed. Next question is, I have this nerve butt pain on both sides and honestly just want to take a knife to this pain myself. And that's actually a common comment that people take. They're like, can you just cut my leg off? Can you just cut my arm off, or what have you, because the pain is so bad. Again, buttock pain like this should be able to be figured out and resolved. It's either coming from the spine or it's coming from a peripheral nerve problem if you're dealing with this level of pain. And so there's a systematic way to do it. My guess is that this person has already had her spine worked up multiple times, and either has already had spine surgery, which didn't help, or the MRI looks normal, more or less, and so the doctors have no real solution for her except probably pain medication, which isn't going to help a nerve problem. I got a patient of mine from Baghdad, Iraq, who says hello. So hello, how are you doing? I don't think I have ground anywhere in my body. I'm not sure I understand that comment. If you'd like to clarify, maybe I could answer it further down. Patient says, had a lumbar fusion at L5S1 in 2002. Right leg and foot pain, still have sciatica symptoms. So, this could be a classic example of assuming, well, let's go back to the beginning. Depending on this patient's age, there may have been some degenerative changes, which may or may not have been the source of the problem to begin with. I can't tell you how many patients I see that undergo completely unnecessary spine surgery simply because of the fact that spine surgeons are blind to peripheral nerves. They're great doctors, great surgeons, and they're highly effective when the problem actually involves the spine. Somebody has a peripheral nerve problem that can closely mimic the same it can closely mimic the same type of clinical symptoms that a spine problem would. That puts the patient at high risk for undergoing unnecessary spine. And again, I don't know the specifics of this patient. I'm just sort of talking in generalities here, but almost all the time, unless the MRI of the back is completely pristine and it's usually a much younger patient, eventually somebody who has bad sciatica pain and sort of equivocal findings on MRI will end up undergoing a spine procedure, partly because the spine surgeon has no idea what else to offer the patient, and partly because the patient is desperate to try anything to get rid of the pain. And so they undergo a fusion or some other kind of spinal surgery, and lo and behold, their symptoms are no different. Now, I don't know, in this particular person's case, it could be a situation where spine surgery took care of one pain and she was left with some pain that never went away, or maybe the original problem was fixed and she developed new sciatica pain after surgery, and then the spine surgeon's confused because the spine surgery was quote unquote done perfectly and all the imaging looks excellent and whatnot. But just for this patient's information, if you've had back surgery and you're still having um, severe sciatica symptoms, and your spine surgeon has made sure that there's not a problem with what went on during the spine surgery, meaning there's not a screw that's impinging a nerve root, or there's no infection, or the hardware's not broken and putting pressure on nerves. If all that stuff has been ruled out, then very likely you're dealing with a peripheral nerve problem, and specifically a condition called piriformis syndrome. Um, then I got about 15 comments saying, yes, I can hear you, so thank you. That was when the video sort of blacked out on my end. Um, here's a patient that says, hard lumps have developed in both palm of my hands. Um, so I'm guessing that what she's describing, it's not a lot of information to go on, but there's a condition called Dupuytren's contracture, which is a condition that affects the connective tissue in the palm of the hand, and that same kind of connective tissue can extend out into the fingers. And so generally what happens is it starts off by developing a hard, sometimes raised lump in the palm of the hand, and this can develop into sort of a cord or string of hard tissue under the skin that can extend out into the finger, and eventually it can even start to pull one or more of the fingers down like you're making a fist, but it only affects the finger or maybe one or two fingers that are affected by this disease. This is not a peripheral nerve problem, so it's not something I take care of, but any well-trained hand surgeon should be able to handle that for you. And I would also say that as long as if you're just dealing with the hard nodules in the palm of the hand, but it's not really a pain issue, then you don't have to do anything about it at that stage. If it starts to affect the finger and kind of pull the finger down, curling it down into the palm, then if that becomes painful, or at the point where it sort of becomes a nuisance, because if one of your fingers is sort of curled halfway, it can be hard to put your hand into your pants pockets or a purse or whatever. At that point, it's a good idea to have surgery and have that corrected, and that's a very correctable problem. You don't want to let it get to the point where the finger becomes really flexed down or curled down, because then that can cause contracturing and can be difficult to get that finger to go perfectly straight again. There's a patient here. This is the same patient. Just made the comment chemo, so I don't know if this patient also has peripheral neuropathy. But again, chemotherapy is a risk factor for developing peripheral neuropathy, because the chemotherapy can affect the nerves, cause them to swell, and develop those compressions that we talked about. But again, it's critical that there's a peripheral nerve evaluation done to see if the patient shows evidence of nerve compression or pinching of the nerves or pressure on the nerves. If the patient doesn't show that, then nerve decompression surgery is not indicated and it won't help them, so you don't do it. Another comment here, it says, oh, this is a patient who had neuropathy, and I operated on them and their pain went away, and so they're just saying thanks, so that's great. There's a statement here that says, can MRI show the peripheral nerve? So I'm assuming that's peripheral, probably just autocorrect, which gets us all frequently, but it says, can an MRI peripheral nerves? Basically, that's the question. And the answer is sometimes. Again, the larger the nerve, the more likely an MRI is going to be able to identify it. But even the biggest nerve in the body, which is the sciatic nerve, is often unable to be visualized well with an MRI. Now, MR neurography is better at doing that, but still, it's far from ideal. I get an MR neurography of the pelvis a lot for patients who have suspected piriformis syndrome. Even if it doesn't really visualize the nerve well or show inflammation of the nerve, which is sort of the smoking gun, it gives useful information about piriformis anatomy and whether or not the nerve may be split and part of the nerve passing through the piriformis muscle, etc. Or it also rules out unusual things like a tumor or something. So it's good for preoperative planning, but there's really not any great way to consistently even identify peripheral nerves. And then the next question becomes, okay, you see the nerve on the MRI. Now, can you make any determination about that nerve? Is that nerve compressed? Is it, is it the source of pain right at the place where you're looking at it? And the answer to that is they're not able to do that yet. There's an interesting group at Stanford who's using MRI imaging and injecting certain like a dye sort of thing. It's a minimally radioactive thing that the concept is really that this is supposed to attach itself to nerves at areas where the nerve may be inflamed or likely to be causing pain, and so therefore theoretically it could help to pinpoint the source of the problem. So that's sort of potentially an exciting new development, but it's a long way from being perfected, and they're just starting initial trials on that. Another patient here says, I have CRPS type 2, in parentheses, nerve damage in my right leg, peroneal and tibial nerve damage. Do you treat this condition? Yes, absolutely. CRPS type 2, again, for those of you who've watched the CRPS Facebook Live video, there's a type 1 and a type 2. And the funny thing is that it should just all be type 2, I guess, because, well, the way that it shakes out is because doctors don't know anything about peripheral nerves. Again, 90% of patients are type 1 and only a small minority, about 10%, are type 2. The main difference between type 1 and type 2 is that in type 2 patients, they're able to identify the peripheral nerve injury. In type 1 patients, they are unable to identify a peripheral nerve injury, but clinically, those two groups of patients are exactly the same. It's not like there's different symptoms in type 1 from type 2. There's been a good study done that shows that about 80%, and it's probably higher, of type 1 patients are really misdiagnosed type 2 patients. So almost certainly there's something that can be done for CRPS involving nerves in the lower extremity, whether they're peroneal or tibial or sural or what have you. Patient here says, do you deal with ulnar nerve pain? Absolutely. I deal with all the peripheral nerves in the body, of which the ulnar nerve is just one of them. Question here says, or comment, so this patient says, that's what my doctor in pain management even admitted. I'm assuming this is in reference to when I was talking about the fact that pain management doctors are not very skilled at actually figuring out where pain comes from. They have tried everything they know except stimulator and have said no. Oh, and the patient has said no to a nerve stimulator for over a year now. Actually, this patient is on the schedule to have surgery, so here in Las Vegas, so that's great. Let's see, other questions. Here's a good one. It says, if nerves have been damaged from a knee replacement procedure, can that cause an extremely intense, muddy, gritty feeling in feet, like they are in a blender that's cranked up 24/7? Yes, I mean, again, as I comment, when a peripheral nerve is happy for any reason, whether that's because it's been cut or it's compressed or it's stuck in scar tissue or whatever the reason is, it can cause all kinds of weird, strange, painful sensation signals that go to the patient's brain. So, I mean, really nothing surprises me anymore, but patients with peripheral nerve problems can describe things like feeling like their foot is in molten lava, or, as in this case, an intense, gritty, muddy feeling like if you were to step in muddy sand and that gritty feeling on your foot. I sort of assume that's sort of what or in the ballpark of what she's describing. It can feel like there's broken glass being pushed into the skin, or barbed wire wrapped around the skin, or somebody running a blowtorch over your skin, or it might feel like the foot is immersed in a bucket of ice water. I mean, the list is endless. It can feel like something's pulling apart or something's being compressed or crushed. Um, that's why this nerve pain is so horrible for patients to deal with. Um, the patient here says she's been wheelchair bound for over 3 years with CRPS. So again, that might be something that can be totally reversed. It just depends. It's a case by case situation. Again, with CRPS, generally, a lot of times CRPS stems from some kind of a surgical procedure or a serious trauma. The more complex it is, and the longer it goes undiagnosed, the more difficult it is to get a good outcome. But that doesn't mean it's not possible. So the patient just has to make the effort to see someone who understands these problems and can evaluate them. Um, there's a question here that says, please explain what nerve pain can feel like. And again, in case it's not clear at this point, nerve pain, or maybe pain is even too limiting a word. Any kind of aggravating, irritating, painful sensation that you can think of can be reproduced or mimicked by a nerve that has been damaged or injured or is otherwise unhappy for some reason. Literally any sensation you can think of. There's sort of one of the fallacies out there amongst regular doctors is that, if it's not a burning sensation, it's not nerve pain, and that is totally false. Nerve pain can mimic any other kind of pain you could feel like. So if you broke a bone, you would feel a certain kind of pain. If your bone had never been broken but the nerve was damaged, it might totally feel like a broken bone to you. Again, it can feel like things are freezing or on fire or being crushed or being pulled apart. Just literally anything. There's anything that. The main thing is not what you're feeling, but it's like, if there's no real explanation for what you're feeling and what you're feeling is bothering you, it's very likely to be a peripheral nerve problem because it's probably a nerve issue. Getting down here to the last question, I think it says, I have spinal stenosis and had surgery to aid in compressed nerve damage to my left knee. I have no relief. I have had nerve blocks and ablations in the past. I usually only get a year or so of relief. Pain meds give no help or give no relief. Again, this is a situation where this person makes the comment like, I have spinal stenosis and had surgery to aid in a compressed nerve which was damaged to my left leg. So again, it's really important to be specific and clear. I'm not sure from this description whether or not the surgery she had was back surgery or surgery aimed at doing something to a nerve that was damaged near the knee. I think probably what this was this patient had pain radiating down the leg and may have had a lot of pain, or most of the pain may have actually been in the knee area, and her doctors diagnosed her with spinal stenosis and spine, but really got no relief from the knee pain. And again, it's really hard to overstate how ignorant doctors are, and spine surgeons are no different about peripheral nerves. So in patients that have peripheral nerve problems, a lot of times it gets to the point where even spine surgeons, they sort of leave their training in a sense and start to do surgery, even in situations that don't even really make sense clinically from a spine standpoint. You're going to try and argue that this is a problem coming from the spine. It makes no sense to argue that. But when they keep seeing the same patient over and over and over again, and the patient is suffering horribly, a lot of times it's sort of something that the spine surgeon will offer in desperation to get, to try something, because doing nothing is not going to change anything. So maybe they'll get lucky, and maybe this is really the source of the pain, or maybe it was sort of a very clear cut spine problem, at least from the standpoint of the spine surgeon, because the clinical symptoms were sort of textbook spine, and then they do the surgery, but yet nothing changes. And that's more of a situation where they could have a peripheral nerve problem that really closely mimics the same kind of pain that you would get if a certain nerve or at a certain level of the spine was compressed, and the spine surgeon is just sort of tricked or fooled into thinking that it's a spine problem when it really isn't. And part of that, again, that really happens most commonly because spine doctors don't know anything about peripheral nerves. They don't know how to check the peripheral nerve side of the nervous system, and to be able to say, okay, wow, there's evidence that there's an obvious peripheral nerve problem there that could cause the same thing. And now that I look at the MRI, there really isn't a great argument there that that's the cause of the pain. So we better go with the peripheral nerve treatment. A spine surgeon is operating with blinders on. All he can see is the spine component of everything. And so that's unfortunately why in a lot of cases surgery on the spine is done, which doesn't result in a good outcome. There's a patient here. Yeah, that patient just commented it was the back surgery. So I'm sort of guessing that this was a situation. Again, you always have to, with the caveat that if something went wrong with the back surgery or there was a complication, that could still end up causing pain. But if the patient has spine surgery to fix some kind of radiating pain in the leg, the spine surgery goes perfectly. They heal it perfectly from the spine surgery, but there's no difference pain in the leg, then almost certainly you're dealing with a peripheral nerve problem at that point. The patient says, does skin breakdown, can that happen from nerve issues? I'm not a diabetic, but my foot keeps breaking down. So this may be a situation where this person may have neuropathy but not be a diabetic. And one of the things that neuropathy does is it very often will produce numbness in the bottom of the foot. And a lot of people are under the misconception that the reason that diabetics and other people get limbs amputated is because they have poor blood flow. And that certainly is a significant reason why that happens. But there's another very common reason, which is that the patient with neuropathy loses protective sensation to the bottom of the foot. And so what can happen is they develop an ulceration over the ball of the foot, maybe over where that big ball that's in the foot, just upstream from the big toe. That's the metatarsal phalangeal joint, or the ball of the foot. And if they don't have good sensation or they don't have protective sensation, let's say they step on a tack or they're wearing shoes that don't fit properly, they can walk around all day long and it doesn't bother them. And then, maybe days or even weeks later, if they're not checking the bottom of their foot regularly, they notice there's a blister or a wound to the bottom of the foot. And then it can be a very difficult thing to get healed because they continue to walk and not offload pressure on that area, even in the face of otherwise good blood flow. And so that can be a component of the nerve compression. There's probably other things that we don't perfectly understand, like sympathetic innervation of blood vessels and how that can be affected. So there could be some focal changes in blood flow to the affected area. But there's been studies that have been done showing that if the patient who has neuropathy and a foot wound and shows evidence of nerve compression, undergoes nerve decompression surgery, that really helps to heal that wound and also really cuts down the risk of developing another wound in that foot down the road almost to zero. So yeah, there's definitely a component of nerve compression or nerve problems that can contribute to chronic wounds, typically in the bottom of the feet, and addressing the nerve issue can really help with healing those types of wounds and preventing those types of wounds from occurring in the future. So it looks like that's the end of the questions. Kind of went long as usual. I always think it's going to take like 45 minutes and it always ends up being like an hour and a half or 2 hours or whatever. But Um, it's enjoyable to do, and I hope that was educational for people. And we'll stop there and have a good weekend, everybody. And I'll see you next time. Bye bye.